को तुम्हें नहीं होनी चाहिए कोविड, पहन लो मास्क, वही मुश्किल है हमारे लिए तो।
No, I can see Arun Khan Aziz as well. Arun, Assalamu alaikum.
Assalam, sir.
कैसे मिजाज हैं?
How are you, sir? Assalamu alaikum. Welcome.
क्या हाल है? मुल्तान के क्या हाल है?
मुल्तान की गर्मी झेल रहे हैं सर, बर्दाश्त कर रहे हैं। और आप खैरियत से हैं?
आम भी आपने खाने होते हैं ना, तो फिर
सर आम आपको भेजे, मैंगोज भेजो आपको?
भेजो ना यार।
चले इंशाल्लाह।
भाई यहाँ पर एक नहीं है, यहाँ बहुत सारे हैं, ये ऑफर सबने सुनी है।
हमने तो कभी खरीदे नहीं है। अरुण हमेशा आते ही हैं वहां से, अभी कल ही आए हैं मुजफ्फरगढ़ से।
अच्छा, नहीं आपके चाहने वाले बहुत है ना।
हाँ, तो आप भी भेज दें
इंशाल्लाह इंशाल्लाह।
एक ट्रक भेज दो।
इश्तियाक तुझे भी मिल जाएंगे यार, तू फिक्र ना कर, कोई पीछे नहीं रहता। वेलकम
भाई। अपने सेक्रेटरी का ख्याल रखो।
नहीं, सेक्रेटरी हमारे साथ है सर, सेक्रेटरी का ख्याल है हमेशा सर।
मेरे ख्याल कोरम तो पूरा है, वी कैन स्टार्ट एक्चुअली if we have enough participants.
10 minutes are left.
We are eagerly waiting.
8 o'clock का टाइम दिया हुआ है।
जी सर, स्टार्ट कर दे, फिर ज्यादा देर हो जाएगी।
Because there are no clinics these days, so everybody is available and before time. Otherwise, everybody would have been sitting in their clinics and offices. Madam Khalda, Assalamu alaikum.
Thank you, sir. I agree with you.
डॉक्टर खालदा का कोई माइक म्यूट कर दे।
Hi, Dr. Bradley. How are you?
Thank you. We are all well.
Good to see you. I'm
Nice to
Zainab
see you as
Samad.
well.
I'll be moderating the session.
Welcome,
So,
Dr. Zainab.
Assalamu alaikum, Dr. Harun. कैसे हैं आप?
वालेकुम सलाम, आप खैरियत से हैं? ठीक हैं?
जी जी बिल्कुल। मैं
Nice
बस
seeing you.
हमारी जी it's great seeing you too. I think what it'll be a good idea if we just go through kind of how the session will go. So first, I think Dr. Ishtiaq Rasool is going to sort of do the welcome and opening remarks, and then with a brief of all the panelists and the speakers. And then I think then we'll sort of just launch, I'll take on as the moderator, and we'll launch into the different talks. I'm hoping that everybody can keep their talk at less than or equal to 10 minutes. We should try and get it done because it's it's 6 speakers. I think our audience is going to tire out very fast. So if we can keep our talk short, around 10 minutes, that would be great. And then I think that people are going to be putting questions in the chat box. So we won't stop after each speaker. What we'll ask is that the speakers, if there are questions coming up pertinent to your talk, that you answer them in the chat box. And then at the end, what we'll do is we'll throw out questions to each of the panelists so that we can get, we can learn from their experience as well. We have 3 distinguished panelists. And then if there are additional questions, it would be great for everybody to learn about, we'll throw them at you. And then we'll have the closing remarks by the president of the Pakistan Cardiac Society. How does that sound?
That's fine. That sounds very appealing. Yes, good.
Okay.
Yes,
Then
one thing to add.
आपको काफी strictly follow करना होगा time wise because the list is quite long.
Yes, the list is long. And so what I'm thinking is for each of the panelists, when you're approaching like 8 minutes, I'm going to send you a private message on the chat box that you're at 8 minutes and you should try and wrap up in the next 2 minutes. Okay. So we'll help you with your time management.
Thank you. I think we should start.
Yes, sir. It's just 4 minutes left. One thing else, every speaker will be sharing her presentation by herself, so that it's more convenient for them while they're running the presentation. So you will be sharing your screens as we go along. And we have like around 4 minutes left, so we'll broadcast this session after 4 minutes.
वही मैं
Till then
बता
we can,
you're free.
till then we all can talk.
Yeah, I think Farhala is having some trouble with her connection as well as her mic, because she's logged on a bunch of times and then she's tried to speak, but we couldn't hear her even when she unmuted. So I'm hoping that that gets sorted. Otherwise,
All right, I'll just call her.
So Dr. Zainab, I just
Yes.
spoke to her. I just spoke to Farhala, Dr. Zainab, and what she's probably going to do is that she's going to join from her cell phone, and she'll have to ask somebody to do the screen share for her because she's having connection issues. It's raining really hard right now, so she's having net connection issues. So, but cell phone उसका ज़रा connect हो रहा है, तो probably वहीं से वो connect करके present कर लेगी. Probably Faizan will have to do a screen share for her.
All right, no issues. I'll be facilitating her from here then.
बस छोड़ जाओ इधर
Actually, I do want to point out one housekeeping thing is that it is raining in Karachi and we end up with a lot of power outages. And so if for us, all of a sudden I decide to go blank, please pick up. I'm going to hope that my other panelists are going to pick up the slack over there. I've got my phone and I'll try and log on through the phone if there's an issue. But if you guys wouldn't mind, just know that there's this background nature's not helping us out right now.
Yeah, I'm just sharing the presentation of Dr. Farhala just to check if it's working properly. So I guess it's minimized. It's moving right now. Everyone can see it's moving.
Yes, Faizan, we can see it, but it's not on slideshow mode.
Yeah. I was just checking that time. I'll ask if Dr. Farhala is.
In program, first talk was of Dr. Eliza. She is on. Can you start with her?
All right, I'll just ask Dr. Farhala. Hello, Dr. Farhala.
Yes, Faizan, can you hear me now?
Yes, I can hear you. All right, no issue.
So I was actually unmuted by you and then you were able to hear me.
Okay, all right. I'm just broadcasting now. We'll be going live in about a second. And Dr. Ishtiyaq Rasool will be introducing the panelists and the speakers. Then Dr. Zainab Samad will take over after that. So and it will be much better that everyone could see Dr. Ishtiyaq. All right, I'm broadcasting now. 1, 2, 3. You all are live now.
Hello, assalamu alaikum and good evening and good morning both. Good morning to my colleagues from USA. It's my great pleasure and honor to host this General Secretary of Pakistan Cardiac Society and my whole team. The president is also that this webinar has been organized by Dr. Khalda Sumro. She's a very dynamic person and she is always on the front foot to organize these sort of seminars and workshops, and always very eager to present data on different issues, especially during the last couple of months, she has taken the topic of pregnancy and cardiology. So as far as I remember, this is the third one. And she's the coordinator of Go Red for Women program, Pakistan chapter. She served for a long time in Dow Medical College as a chairperson of cardiology department and in the capacity of professor of cardiology. And what is very important is that she also holds the unique honor of being first woman president of Pakistan Cardiac Society. So 2 years back, she was the president of Pakistan Cardiac Society. Unique thing is that she has donated the office for Pakistan Cardiac Society. So she has a very big respect among us. And with us, we have some other big names and very prominent figures in cardiology who are with us and chairing this session. And the first one is, which I will name is Professor Abdul Samad. In one word, what I will say that he is the teacher of teachers. He is currently the Director Cath Lab and Chief of Cardiology in the United Medical College. He has a great contribution in the establishment of National Institute of NICVD as an academic, research and teaching center. Doubt to say that he was the backbone of NICVD. He was the project director and the first executive director of Karachi Institute of Heart Diseases. He is the co-founder of Pakistan Cardiac Society. This is also, you must remember that this Pakistan Society, when established, he was among the co-founder, and he remained as a General Secretary of Pakistan Cardiac Society for about 35 years. So he has a very big contribution in the foundation, establishment, and the working of Pakistan Cardiac Society. And it is always a pleasure and great learning to listen to him. And with us is also Dr. Harun Baba. He is the current president of Pakistan Cardiac Society. He is my colleague, a renowned cardiologist. And with his enormous contribution in the field of cardiology, especially in Multan, he established the interventional cardiology program in National Medical College in Multan. And he is currently, as I told you, that having the chair of president in Pakistan Cardiac Society. And under his dynamic leadership, we have managed to develop such for women program in Pakistan. And with us, we have Dr. Mohammad Ishaq. He's a very pleasant. We love him very much. He is currently the professor of cardiology in Karachi Institute of Heart Diseases and visiting faculty in Aga Khan University Hospital. He is the head examiner in College of Physician and Surgeon Pakistan for FC's fellowship in cardiology examination since so many years. He has also served as a professor of cardiology and as a unit head in National Institute of Cardiovascular Diseases. He was also the executive director of Karachi Institute of Heart. He is the co-founder of Pakistan Hypertension League. He was the president of Pakistan Hypertension League, and currently he is the General Secretary of Pakistan Hypertension League. Now I come to the more practical part of the webinar, and that is the speakers and about the presentations. Professor Zainab Samad will conduct the session throughout the webinar as a moderator. So she is the main person here who will be controlling the webinar. So we must listen to her. And she is very, very precise about the timing. That I know, because in the last webinar we were together, and as a she played a very wonderful role. So Dr. Zainab is actually, she is the head of medicine department in Aga Khan University Hospital. She is a consultant cardiologist and an accomplished researcher and academician. She has a great passion for teaching. She is the daughter of worthy Professor Abdul Samad. And I feel that Dr. Samad daughter sharing the same platform. We have 6 talks in this webinar, and Professor Zainab will give you the details. I will just name the speakers. 6 speakers. Dr. Eliza Bradley from Ohio Medical University, USA. Dr. Uzma Khan from University of Missouri, Ohio, USA. And Dr. Garima Sharma from Johns Hopkins University. Dr. Najma Patel from National Institute of Cardiovascular Diseases, Karachi. Dr. Farhala Baloch from Aga Khan University Hospital. And Dr. Saira Bukhari, also from Aga Khan University Hospital. With this brief introduction, I give microphone to Dr. Zainab Samad to conduct this webinar. Thank you.
Thank you very much, Professor Dr. Ishtiaq Rasool, for that very kind introduction to the session. I'm going to ask everybody who is not speaking to put their mics on mute. And then what we will do is we'll launch into the sessions. I'm going to a few housekeeping things. I would like to just request all the speakers to keep their talks under 10 minutes. We are not going to have any breaks. We will kind of breeze through all of this because the time is limited and we have 6 speakers. Please, for all participants, if you wouldn't mind putting your questions in the chat box, and the speakers are requested to actually answer after their talks, if they can, the questions in the chat box. At the end, we will have a Q&A, and we will highlight the big questions that have been asked in the chat box. We'll put them to the speakers as well as some other questions to the panelists. So we're really excited to have you all join us on this very exciting session on pregnancy and heart disease. Pakistan has one of the highest maternal mortality rates in the world, and heart disease plays a really important in contributing to that mortality. So without further ado, we're gonna, I'd like to introduce our Dr. Eliza Bradley, who is an assistant professor of clinical cardiology at the Ohio State University College of Medicine, and has privileges at both Nationwide Children's Hospital and the Ohio State University Wexner Medical Center. She will be discussing congenital heart and valve disease during pregnancy. Over to you, Dr. Bradley.
Thank you, and thank you for the invitation to speak here today and be with all of you. I'm hoping everyone can see this screen I'm sharing right now. I'm going to talk about congenital heart and valve disease in pregnancy, and specifically focus on those women who have modified WHO class 4 lesions, so lesions that are very difficult to manage in pregnancy and high risk. These are 2 statements I'll refer you to, and if you want to look back at any of present here, one is the scientific for acquired heart disease in pregnancy, and the other for congenital heart disease. The objectives of in terms of how we look at these anatomically, then we'll talk about how to define modified WHO classification and risk. And this is so that you understand which patients are at increased maternal risk. We'll then talk about how to consider which women are at the highest risk category. And this is really so that you understand who might benefit from referral or being at a center of excellence. And then finally, we'll talk about evidence, or in some cases, the lack of evidence that occurs when we're managing women with these very complex lesions. And this is just to give you a taste of how that looks in a center where we care for a lot of high risk women. So to start with the first, looking at congenital heart disease, just as a reminder, there's an anatomic and physiologic classification. Sorry. There's anatomic and physiologic classification of disease. So defects that you see here are classified as simple. These are small, isolated septal defects, mild pulmonic stenosis. Then you have a lot of defects that fall into that moderate category. And so you can see there's a lot of different kind of spread of disease here, but I would draw your attention to the congenital aortic and mitral valve disease, as well as coarctation of the aorta, as you'll see some cases that I'll show you in just a moment of patients with these lesions. And then finally, there are those with severely complex congenital heart disease. This is any of the single ventricle disorders, Fontan palliated patients, or cyanotic patients. So I'm going to go over a couple of cases to illustrate some points for you today. So these are patients that showed up in our center. This is a 39-year-old woman who came in who has a bicuspid aortic valve and known supravalvular stenosis, and she was pregnant with in vitro fertilization. She is a G2P0, and her past medical history is that at age 5, she had a balloon valvotomy. At age 17, she had aortic valve repair and patch augmentation of the root. And then 6 years prior to the current presentation, the mean and peak gradients across this valve were 38 and 60. And you can see some pictures here from the echocardiograms that there was evidence of a poorly moving aortic valve, and there's flow acceleration at the valve level and above the valve. And so at this point in pregnancy, her mean and peak gradients were roughly 50 and a little bit over 100 millimeters of mercury for the peak. The second case is a 27-year-old woman who's a G6P5, and she came in with pulmonary edema during the second trimester of pregnancy. She had no prior surgeries, and you can see here that she's got an enlarged left atrium, and she's got thickened mitral valve leaflets consistent with rheumatic disease. The mean gradient across the valve at this point in time was 22 millimeters of mercury. Case 3 is a 28-year-old woman who was a G1P0, and she had a personal history of hypertension and had been on 2 medications since the age of 15. She received a CT scan of her chest, which showed this, which was the near interruption of the aortic arch. So this is a very severe coarctation with well-developed collaterals in both the anterior and posterior chest. Case 4 is a 35-year-old woman, and this is a lady who had known atrial septal defect and pulmonary arterial hypertension. She was diagnosed 2 years prior. At that time, her hemodynamic cath showed a mean PA pressure of 47 and a PVR of 6.5 Wood units. She was currently a G4P2 when we saw her, and she was 30 weeks along in pregnancy on sildenafil therapy. Her pulmonary pressures were roughly around 80 to 90 millimeters of mercury as estimated by echo. So we're going to move along and kind of ask ourselves, how do we risk stratify these women that come in with cardiovascular disease? And we'll talk about that modified classification system. You can first go back, we'll kind of go over a couple of other mechanisms. So CARPREG came out in 1994 and was then updated in 2018. And this is a system where patients are assigned risk points based on different types of characteristics present. So you can see there are a lot of similarities here in blue. So prior cardiovascular events, advanced functional class, left heart obstruction, and systolic dysfunction are all really important things that, that do elevate a woman's risk. And then based on the number of points that they have, you can estimate the likelihood of a maternal cardiovascular event. Now in the CARPREG 2, all of the yellow circles that you see were additional things that were added just a couple years ago. So the presence of mechanical valves, pulmonary hypertension, coronary disease, amongst other things. So these have more recently in the literature been demonstrated to increase risk even further. So the Zahara is another classification system that is somewhat similar to CARPREG. It again functions using point systems that really outline many of the same things. So advanced functional class, the left heart obstruction, arrhythmia, but then I draw your attention to the mechanical valve prosthesis, which in this case has been found to increase a woman's risk of a cardiovascular event substantially, up to the order of 70%. And so it is just another classification system that could be used. Now, many centers will use this, which is the modified World Health Organization classification system, and it's really the only one that's been well documented and studied prospectively, so we do tend to use this in our center as well. You can see here there's sort of these lower risk conditions, WHO 1, 2, and 3, and there's both congenital and acquired disease. The maternal cardiovascular event risk in those cases is about 1 in 5. Those that are on the right-hand side of your screen, the WHO class are women who have a little bit higher risk. So up to about 1/3 of women would have an event, a cardiovascular event in pregnancy. And these are things like mechanical valves, at least moderately reduced systolic function, some of the cyanotic congenital heart defects and aortopathy. But then today we're going to kind of focus on these. And this is women who fall into that WHO 4 category. So these are women who are at highest risk of a maternal cardiovascular event. So things like pulmonary hypertension, severe systolic dysfunction, vascular Ehlers-Danlos syndrome, or severe recoil. And the maternal cardiovascular event rate in these women is somewhere upwards of 40 to 100%. So now that we kind of know some things about how to risk stratify folks, then what is the evidence behind how we manage these patients? So this was nicely put out in the most recent Carr-Prague paper, and it really just gives you an outline of how to start out thinking about what are the things by history that the woman has that increases her risk, and then what are the specific cardiovascular disease characteristics. So is there a mechanical valve presence, for instance? And then finally moving on to imaging or to other diagnostic techniques that help to further risk stratify. And I would say the blue box on the bottom is also important, because sometimes not all of these features can be put into the normal algorithms for risk stratification. So they may have rare disease that's not well studied, or they may have presented late. They may also have other disease such as diabetes or hypertension that contribute to the complexity of their case. So we'll review a couple of considerations in terms of management. So you saw our case of the woman with pulmonary hypertension. This is data from ROPAC, which looked at specifically just the pulmonary hypertension group. And they found that there were 39 women. Most of those actually had congenital heart disease, and only 7 with idiopathic pulmonary hypertension. And then there were a lot of women who had left heart disease. And so how did they do? What we saw was that maternal death was more common in the cohort. It was actually only around 7% in the congenital cohort in this group. Now, this is a systematic review that was done between 1997 and 2007. And you can see that congenital heart patients, which are in the middle there, most of them, I shouldn't say most, about half of them were on fairly good therapy. They were on nitric oxide, prostacyclins, bosentan, sildenafil, and roughly 48% of them were on no medication at the time of the pregnancy. But if you look in the bottom boxes, you can kind of see what happened to these women. And many of them did die, and they died either before delivery, or in the case of most, right around that time, kind of postpartum and immediately postpartum. And the most common cause of death really was circulatory failure or right ventricular failure. Now, if you look at data that came, this study looked at 2 cohorts of data. So data that went from 97 to 2007, and then older data from 1978 to 1996. And in all PH patients, no matter what subtype, there's been a significant reduction in mortality. And we believe that's because of 2 reasons: better access to medications and more medications available, as well as recognition of the disease process. This is currently what our institution uses to manage women who have pulmonary arterial hypertension and elect to move forward with pregnancy despite the high risk. And it involves reassessing with imaging frequently. It involves titrating pulmonary hypertension medications and putting every single patient on prostacyclin therapy if they qualify for that. So we'll talk about left heart obstruction next really briefly. This is some data looking at mitral stenosis specifically that comes out of Toronto. And what you can see here is that they evaluated event rate, meaning anything that happened to the patient, maternal cardiovascular events, specifically in fetal events. And what you see is that the more severe the mitral valve disease is, the more likely these patients are to have events, and specifically cardiovascular events. In those patients who had severe mitral stenosis, you had an over 60% chance of having a maternal cardiovascular event. For aortic stenosis, this was a study that looked at maternal cardiovascular admissions across Europe. This came out of the ROPAC data set as well. And really what they found in this group of patients, there were around 150 women who met criteria, is that if you had severe aortic stenosis, your chance of admission was still not terribly high. It was around 40%. If you had severe disease, it was around 20% for all comers. All women in this cohort were managed medically, with the exception of one who received a balloon valvuloplasty. And all women did well. There were no deaths. We did try to evaluate in our center whether mitral stenosis versus other left heart obstructive lesion, which is LHO here, which lesions were were pretending higher risk in women. And what we found was that if you had mitral stenosis versus any other location of a left heart obstruction, the odds that you would have an event were significantly higher, right around 18 in this study. We also found that if you had more than one, so serial lesions, then you ended up having an odds ratio that was still fairly high, 6 times that versus just one left heart obstructive lesion. So for those patients, we tend to manage them medically. We monitor heart rate and blood pressure. There's often looking at monitoring types of things during the peripartum time, so central venous catheters and arterial lines, making sure that you manage heart failure early if it happens in the early postpartum. So just to follow up on the cases and based on some of the data I showed you here, remember that first lady, she had a bicuspid valve and she had significantly elevated gradients at the time she presented. So she delivered at 40 weeks and 3 days for failure to progress, and the mean and peak gradients were 61 and 108. She did receive a valve surgery about 10 days after she delivered, and she did well. The second case was the woman with mitral stenosis with a mean gradient of 22 and some early signs of heart failure in the second trimester. She had a normal spontaneous vaginal delivery with no maternal cardiovascular events, but we had to watch her blood pressure and volume very closely. She had an arterial line and a central venous catheter at the time of delivery and did deliver in our heart hospital. Case 3 was the woman with severe coarctation of the aorta and already on 2 antihypertensive medications. She received percutaneous balloon valvuloplasty of the coarctation and a covered stent to that area when she was 10 weeks along. She was tapered down to 1 blood pressure medication, and then she had a normal vaginal delivery afterward with no cardiovascular events. Case 4 was the woman with an atrial septal defect who had pulmonary arterial hypertension. And she was admitted at 30 weeks, and we initiated her on IV prostacyclin therapy, which we titrated to 20 nanograms, and continued her sildenafil throughout the pregnancy. She delivered at 37 weeks without any maternal cardiovascular event and did receive an assisted second stage of labor and was monitored in our heart hospital during labor and delivery. So this is my last slide, and I really just say that you can't do this alone. It certainly at our center takes our maternal fetal medicine colleagues, high-risk anesthesia team, and our nursing teams, as well as our cardiology team and congenital cardiologists. And I will certainly answer any of your questions in the chat box. Thank you.
Thank you, Dr. Bradley. That was a fantastic talk and really drove home the points that left heart obstruction and PH are difficult lesions to deal with in pregnancy. And if one is to get pregnant or does get pregnant with those, that a multidisciplinary high acuity care facility is required for their care. So thank you very much. That was a fascinating talk. I would encourage the participants to post their questions in the chat box, and if you wouldn't mind answering them there. Our next speaker is Dr. Najma Patel. She is a most eminent pediatric cardiologist in Pakistan, and her journey dates back to 1994 when she started at the National Institute of Cardiovascular Diseases as a fellow and is now serving as the chairperson of the Pediatric Cardiology Department and Pediatric Cardiac Services. She has a vast experience with dealing with congenital heart defects of all ages in Pakistan, and she will be discussing pregnancy with complicated congenital heart disease. So over to you, Dr. Patel.
Thank you, Dr. Zainab. Actually, there is very much overlap between my talk and Dr. Eliza's talk. So I can finish it within a few minutes. Okay. Incidence of congenital heart disease 7 to 10 per 1,000 live births around the world. Advances in medical and surgical treatments has led to more than 85% of these infants surviving into adulthood. In next 2 decades, it is estimated that 1 in 100 adult patients will be having congenital heart disease. Half of this will be women. For the majority of, patients with milder forms of congenital heart disease, the ability to conceive and carry pregnancy to term will present little problem. For those with complex congenital heart disease, pregnancy may be associated with increased risk, regardless of whether they are clinically stable at the time of conception. The ability to bear children is a major point of care for this growing population. As a result, pregnancy counseling and management are among the major non-cardiac issues facing pediatric and congenital heart defects providers. I'm skipping this slide. Hemodynamics. Or we can go. Results of all the hemodynamic changes is that as the systemic vessels fall, there is variable effect on shunt lesions. If there is mostly increase in left to right, right to left shunt, which causes increase in cyanosis. These changes may lead to congestive cardiac failure. This increased volume may lead to increased gradient across stenotic lesions, and these all may result in maternal fetal duration in women with congenital heart defects. Periods during pregnancy when danger of cardiac decompensation is high due to hemodynamic changes are pregnancy during 32 to 34 weeks, labor, and the period, first 10 days. Our experience for country are this, that most women are diagnosed first time during pregnancy. Sometimes parents have that effect. Many are diagnosed after multiple pregnancies. Majority are referred in third trimester. Counseling of those who are diagnosed earlier is not done properly. Even if counseling is done, parents do not follow that because of the social constraints. Couples, when aware of the problems, do not avoid pregnancy if it has been advised, but surprisingly, they are very much ready for having abortions. My topic was complex congenital heart disease. A designation of simple versus complex congenital heart disease is not adequate when referring to patients with congenital heart disease during pregnancy. Every simple lesion may become complex. Many simple lesions are high risk for pregnancy. Like in VSD, if it is very small, it doesn't harm anything. But if develops AR, either due to prolapse of or secondary to infective endocarditis, may develop LV dysfunction. Likewise, ASD, if develops arrhythmias, ventricular function or pulmonary arterial hypertension. Even this occurs after closure of the ASD also. Any PD or any other lesion, if have PH at pulmonary hypertension at the time of surgery, may develop pulmonary arterial hypertension several years after surgery. Dr. Eliza has gone through all this classification, SIM group 1, group 2, group 3. I am skipping this. Pregnancy care of women with congenital heart disease involves preconception planning and assessment. That is a very important part of the management. Care during pregnancy, care during delivery, and the postpartum period. Risk assessment should be done before marriage in patients known to have congenital heart defects or as soon as diagnosed to have congenital heart disease after pregnancy. And the risk estimation needs to be re-evaluated during each pre-pregnancy visit because the risk of complication may change over time. Preconception planning include counseling for cardiac risk for mother, obstetric risk of fetus, and fetal and neonatal risk of congenital heart disease in offspring, maternal or paternal if the father has congenital heart disease, life expectancy, contraception, modification of cardiac medications, level of surveillance during pregnancy, during a need for treatment, and anticipated hospitalization required during pregnancy. Risk assessment, Dr. Eliza has described all these things. Mostly we are using the Modified World Health Organization. These you can see she has most of the complex, moderate and complex lesions come into category of 3 and 4. Assessment for environmental risk factor is also important because the patient may have diabetes, hypertension, infections, and may be taking teratogenic medications or alcohol and smoking. Or assess before planning of pregnancy in all cases of congenital heart disease, whether repaired or not. Following must be evaluated: detailed history, including any current cardiovascular symptoms and family history, review of medication for benefits and risks with appropriate adjustment, functional class, oxygen saturation, ECG for detecting any arrhythmias if need Holter monitoring, may need Holter monitoring, echo to assess of any valve obstruction or regurgitation, whether native or post-operative, ventricular functions, pulmonary hypertension, any obstruction in post-operative patient with conduit or surgically created pathways or baffles. And they may need, sometimes if they come before pregnancy, they may need cardiopulmonary or exercise stress test to detect what is the limitations. Additional testing may include imaging or non-invasive studies for detailed anatomy, ventricular function, integrity of valve function, calculation of shunt, or determination of the pulmonary hypertension. Pre-pregnancy patient may need cardiac catheterization to assess pulmonary hypertension. Dr. Lisa has discussed these predictors of and all reduced systemic ventricular systolic function. Oh, it is also important. AV valve regurgitation, repaired cyanotic heart disease, cardiac catheterization, cardiac medication before pregnancy, cyanosis, saturation of less than 90% carries a very high fetal mortality. Mechanical valve processes, smoking history, and pro-BNP levels. The predictors of neonatal events are cardiac medications before pregnancy, function class 3-4, mechanical valve processes, maternal decline in cardiac output during pregnancies, maternal left heart obstruction, low maternal oxygen saturation, and use of anticoagulation throughout pregnancy. Maternal congenital heart disease is a major determinant of risk and to the neonate, resulting in the following: high frequency of spontaneous abortion ranging between 15 to 20%, high preterm birth rate, especially in those with complex congenital heart disease, high perinatal mortality, may be fourfold higher than in general population. And then neonatal events also, there is a high risk of for gestational age, respiratory distress syndrome, interventricular hemorrhage, and neonatal deaths. Recurrence of spring is very important to counsel the recurrence risk. Genetic counseling should include the assessment of genetic risk factors, which include recurrent risk largely depends on the type of lesion which the mother or the father have, and family history of congenital heart disease if present. Recurrence risk varies between 3 to 12% compared with the risk. There is no history of affecting having the congenital heart defects in siblings or the immediate family members, and the risk is only 0.8%. Otherwise, it increases to 3 to 12%. Most genetic conditions associated with congenital heart disease are also autosomal dominant condition, which have a transmission risk of about 50%. Marfan, Holter-Rand, Noonan syndrome, Charles, Williams syndrome, this recurrence is 50%. For suggestion for genetic testing, if patient has 3-generation family history, including any consanguinity, should be completed. Genetic evaluation should be made available to all women with congenital heart disease to determine recurrences, particularly those patients with a family history of congenital heart disease and with possible dominant lesions. High frequency of recurrence of congenital heart disease underscoring the need to offer fetal echocardiography to all all pregnant women with congenital heart disease at 12 to 28 weeks should have fetal screening. What are the potential hazards during pregnancy and labor? Arrhythmias, congestive cardiac failure, cyanosis may increase, thromboembolic events, dissection of aorta, depends what the lesion patient have, hemorrhage due to bleeding, diathesis in cyanotic patients. The level of antenatal care and monitoring required should be determined before pregnancy or as soon as pregnancy is confirmed. Patients with functional class 3 or 4 should ideally be cared for in a tertiary multidisciplinary hospital. Hospitalization during the third trimester of pregnancy and some patients which for bed rest, closure cardiovascular monitoring, oxygen therapy, patient admit. Treatment during pregnancy, patient may need intrathecal endocarditis prophylaxis, antiplatelet therapy. Patient should have maintained adequate hemoglobin level, bed rest, oxygen. For severe stenotic lesions, relief of obstruction, like in MS and aortic stenosis. Preterm delivery in patients with ventricular failure. Vaginal care during and the postpartum period. Vaginal delivery carries a low risk of complication for both mother and the fetus than C-section, which is very important. Prolonged and difficult labor should be avoided. Pain management is very important. Labor should not be induced unless for obstetrical indications or because of developing cardiovascular compromise. The controlled vaginal delivery with the it is a very dangerous period, actually most dangerous period, early period. Oxytocin drugs such as oxytocin and ergometrin should be used with great care. Management of the early postpartum period should aim to avoid fluctuations in blood volume and blood pressure. Ongoing monitoring is necessary in high-risk patients during the period. And then patients may need counseling about the contraception. Combined oral contraception should be avoided in patients at risk of thromboembolism. Progesterone-only oral contraceptives do not increase the risk of thromboembolism. An intrauterine device impregnated with progesterone for patients with high risk of pregnancy-related complications of thromboembolism is advisable. Sterilization should be considered for women in whom pregnancy would carry a prohibitively high risk. Termination of pregnancy in class patients who are in modified WHO classification of 4. Termination of pregnancy is indicated in the first trimester. Suction curettage under local anesthesia is the preferred method. Medical abortion is probably contraindicated because of the hemodynamic effects. Women with congenital heart disease have high risk for maternal and fetal complications. All women pre-conception or during pregnancy should be referred to adult congenital or pediatric cardiologist who has small or mild lesions or irrespective of symptoms, post-operative or interventions. There must be collaboration among various specialties like congenital cardiologists, any type of cardiologists who are dealing with adult obstetricians, anesthesists, and neonatologists. A patient with congenital heart disease are surviving long due to increasing facilities. So number of pregnant women with congenital heart disease is increasing. A new group of patients with single ventricle physiology is emerging. All these texts need knowledge about the care of women with congenital heart disease. Thank you.
Thank you, Professor Najna Patel. That was a really fascinating talk. And I know that there was overlap between your and Dr. Bradley's talk, but as far as this high-risk group of patients is concerned, I think repetition is a good thing for people to take away important messages. And I think your talk also added a lot of context to our area, just even understanding that a lot of these women present for the first time during pregnancy. And how things like termination of pregnancy are dealt with in our culture. So really appreciate your talk. Our next speaker is Dr. Sayyeda Saira Bukhari, who is an assistant professor of cardiology at Khan University. She will be speaking about pregnancy and pulmonary hypertension. Over to you, Saira.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you for that introduction. So my job has been made much easier by Dr. Eliza and Dr. Najma Patel. I will be speaking about pregnancy and pulmonary hypertension. So the way I'm going to do is that we're first going to talk about pulmonary hypertension per se. And we'll speak briefly about the epidemiology of pregnancy and pulmonary hypertension. We will then go into the physiological changes that occur during pregnancy and how pulmonary hypertension interacts with that. Then we will go on to the management of pregnancy when it occurs in somebody with pulmonary hypertension. And finally, we will be speaking about prognosis. Then to start with pulmonary hypertension, we are all aware that pulmonary hypertension is a hemodynamic and a pathophysiological condition, which is defined as an increase in mean pulmonary arterial pressure above 25 mmHg at rest. And this definition is based on right heart catheterization. However, it is more commonly diagnosed through echocardiography. WHO has classified pulmonary hypertension into 5 groups, but as cardiologists, we are more familiar with dealing with group 2, which is pulmonary hypertension with left heart disease. However, that does not let us off the hook, because we often have to deal with other forms of pulmonary hypertension since there is significant overlap. Speaking about the hemodynamic definitions of pulmonary hypertension, traditionally left heart disease leads to post-capillary pulmonary hypertension, which is increased pulmonary arterial pressure with an increase in wedge pressure. However, as mentioned earlier also by Dr. Najma Patel and Dr. Eliza, there can be combined pre and post-capillary pulmonary hypertension, and this occurs more with congenital heart disease, but also to some. So, well, this is a bit of a busy slide, but this is roughly the diagnostic algorithm for pulmonary hypertension. Again, cardiologists play an important role here, both in the diagnosis as well as in the management of pulmonary hypertension. The important signs and symptoms of pulmonary hypertension in those who have not been diagnosed previously may mimic workup. So it is mandated for all cardiologists and cardiology trainers to think about it and educate themselves about this condition. There is very little data about pulmonary hypertension and pregnancy. We have regarding outcomes of pulmonary hypertension and pregnancy. This was also shared previously, and as you can see, and this kind of matches our clinical experience as well, Group 1 consists of around 26% of cases with pulmonary hypertension. But again, as rightly pointed out, a lot of Group 1 pulmonary hypertension may actually be left heart disease in this context of congenital heart disease. Group 2, as much as our experience, 75% of patients in the ROPAC registry consist of Group 2 hypertension, of Group 2 pulmonary hypertension. Of this, again, not surprisingly, valvular heart disease, specifically mitral valve disease, predominated in the cases of pulmonary hypertension. This is a well understood diagram of the physiologic changes that occur during pregnancy. But we should look at them in the context of pulmonary hypertension. What is usually seen during pregnancy, and these hemodynamic changes actually peak during the second trimester. And the changes that do happen are a decrease in systemic vascular resistance, an increase in cardiac output, an increase in coagulability, an increase in oxygen consumption, an increase in blood volume. Now, to understand what happens to such a patient who has pulmonary hypertension and becomes pregnant, because this is going to be a bit of a disaster. With increase in SVR and cardiac output, there can be increase in right to left shunt. With increased coagulability, there may be an increased risk for pulmonary embolism. And with an increase in blood volume and oxygen consumption, there is increased risk for RV failure and RV dilatation. Concomitant with that is a failure to decrease pulmonary venous resistance because of vascular resistance because of fixed pulmonary hypertension. And because of that, LV underfilling occurs. So then the common pathophysiologic pathways are hypoxia, and some blood loss, and inducement of vasovagal reflex. All of these can cause hypertension, acidosis, and a final common pathway of a downward spiral of increased PVR, shock, and respiratory failure. With regards to management, a multidisciplinary approach and an intensive care of both pre, intra, and postpartum is required. So we will be speaking about management in terms of preconception, antepartum, birth, and postpartum. So I've kind of tried to summarize the current guidance on how to manage patients with pulmonary hypertension, and there will be overlap between pulmonary hypertension due to other causes and pulmonary arterial hypertension, which is group 1. So in the preconception period, there is also an important consideration in patients without pulmonary hypertension. For those patients who do not have pulmonary hypertension, but may be taking SSRIs, it is now known to be associated with the development of persistent pulmonary hypertension of the newborn. So it may be advisable to consider a risk versus benefit assessment. For patients who have pulmonary hypertension, those who are category 4 should be counseled to avoid pregnancy. And if they do fall pregnant, there should be an early referral to an experienced pulmonary hypertension center. As with regards to contraception, permanent hysteroscopic contraception should be strongly considered. Other methods such as tubal ligation, for them, mini laparotomy is considered to be safer. Estrogen-containing contraception is contraindicated. Progestin-only pills may result in high failure rates, so a second method is also preferred. Injected progestins, such as Depo-Provera, are relatively contraindicated because there's an increased risk of thromboembolism. So they can only be considered in patients who are already on anticoagulation. With regards to genetic counseling only in the context of pulmonary hypertension is only considered to be offered for patients who have idiopathic or heritable forms. For groups 2, 3, 4, and 5, it is generally not recommended unless the condition, such as the left heart disease, is due to a heritable cause, such as cardiomyopathy or congenital heart disease. With regards to management, there are well-defined treatments for group 1 prime, and group 4 pulmonary hypertension. However, optimal treatment for groups 2, 3, and 5 are debatable. And however, there's now growing evidence for use of pulmonary arterial hypertension medications in conditions caused by left heart disease. So some general principles of management include considering the highest risk periods of pregnancy. So we do know that most patients will become symptomatic during the second trimester, but the highest risk periods for sudden cardiac death and complications are peripartum and immediate postpartum. However, this risk may extend up to 2 months postpartum. So we can actually not let our guard down. A multidisciplinary approach is recommended. As rightly pointed out, it does take a village to do this job. Close clinical monitoring is required. Due to the evidence found in the ROPAC registry, they found that the highest risk for sudden cardiac death occurred 1 week postpartum. Therefore, they recommend that postpartum in-hospital observation should extend up to 1 week postpartum. Pregnancy termination should be offered to patients who develop right heart failure, especially if they develop it early in pregnancy. And counseling should be done to both the patient and patient care providers for inducers and symptoms of vasovagal syncope, since this may result in catastrophic outcomes. Referral should be made to a pulmonary hypertension center for management. Vaginal delivery is preferred, and cesarean section is only recommended for obstetric reasons. Epidural or spinal epidural anesthesia is preferred because it causes less decreases in SVR. Timing of delivery depends on clinical conditions and RV function. However, early planned delivery around 32 to 34 weeks may be considered in patients who have moderate to severe pulmonary hypertension. Specific therapies, which are pulmonary arterial hypertension therapies, may be used during pregnancy. If pregnancy is continued and pulmonary arterial hypertension therapy has never been initiated, then it is recommended that it should be initiated at least 3 months prepartum and should be continued at least 3 months postpartum. Oral phosphodiesterase 5 inhibitors may be considered in patients who are function class 1 and 2 and who have normal RV function. Inhaled prostaglandins may be recommended in select patients with more preserved RV function who are function class 3. Parenteral prostaglandins are considered in patients who are function class 4 and who have severe RV impairment. Parenteral prostaglandins may be combined with oral phosphodiesterase inhibitors in pregnancy. This is generally not done outside pregnancy, but it has been studied and documented during pregnancy. Therapies to be considered at the time of delivery include IV prostaglandins in appropriate patients. Close monitoring includes CV, central venous pressure monitoring, invasive arterial monitoring, and attention to volume status. And diuresis postpartum has been recommended to prevent progression to RV failure. Sorry. Endothelin receptor blockers and soluble guanylate cyclase stimulators are pregnancy category X. If they are, some patient is already on them, they should be stopped and they should not be considered during pregnancy. As far as anticoagulation is concerned, risks and benefits of this therapy should be reevaluated. Warfarin should ideally be stopped after during the first trimester, and other unfractionated heparin or low molecular weight heparin should be considered. Prophylactic heparin should be considered in the peripartum period. Newer oral anticoagulants are currently not recommended because there's not enough data to support their use during pregnancy. For type 2 pulmonary hypertension, therapeutic considerations consider specific pulmonary hypertension specific therapies only for those who have a transpulmonary gradient suggestive of precapillary component. Other management is based on guideline-directed therapy for each disease, example, mitral valve disease, HFrEF, etc. Prognosis for pulmonary hypertension may vary according to RV systolic pressure. We understand that pulmonary hypertension is a variable beast, depending on the type of pulmonary hypertension and also according to RV systolic pressure. So the REOPACT registry actually classified outcomes according to RV systolic pressure. So we can see here that maternal mortality mostly occurred in patients who had RV systolic pressure above 70 mmHg. However, for heart failure and small birth weight, outcomes were kind of uniformly distributed across all kinds of pulmonary hypertension. With regards to the group of pulmonary hypertension, we can see that left heart disease had a significant burden with regards to heart failure and small birth weight. However, maternal mortality mostly occurred in type 1 pulmonary hypertension, and of these, congenital heart disease had the highest mortality. With regards to fetal and neonatal outcomes, congenital heart disease-related pulmonary hypertension had the highest morbidity and mortality, and patients who had left heart disease did relatively better. However, these differences across these four groups were not statistically significant. So to summarize my presentation, patients with pulmonary hypertension require early diagnosis, aggressive appropriate management, early referral to a specialist center, and multidisciplinary approach. Counseling especially is regarding avoidance of pregnancy and contraception, and intensive management and follow-up, peripartum and postpartum. Thank you.
Thank you, Saira. That was a wonderful talk on pregnancy and pulmonary hypertension. There are some questions in the QA box for Dr. Patel and Dr. Bukhari already. If you all are requested to please answer those in the QA box. Our next speaker is Dr. Garima Sharma, who is an assistant professor of medicine in the Division of Cardiology at Johns Hopkins University School of Medicine. And she will be talking about hypertension and pregnancy and postpartum. Over to you, Dr. Sharma.
Thank you. Okay, so I am going to actually shift gears a little bit. I know Dr. Bukhari and others have spent some time talking about pulmonary hypertension. I'm talking about systemic hypertension, something that cardiologists don't really manage a whole lot during pregnancy. It's usually managed, at least in the United States, by MFM and OB exclusively. But the gist of this talk is to really give everybody an understanding of how and why hypertensive disorders in pregnancy are important, not just during pregnancy, but they also have long-term consequences. So I'm very happy to be here. And assalamu alaikum. I have a lot of Pakistani friends, and it's fantastic this has been put together by AHA and the Pakistan Cardiac Society. I'm very happy to be here. I have no disclosures. I do have a disclosure. I am a very big Wasim Akram fan, and I'm very sorry that he doesn't play anymore. And so I stopped watching cricket after he retired and after Sachin Tendulkar retired. So I focused my attention on American sports now, and I'm a very big Ravens fan, so, you know, go Ravens. But anyway, so happy to be here. Four main objectives of my talk. I'm going to discuss hypertensive disorders on pregnancy, the overall scope of the problem, spend a little bit of time talking about ACOG, which is American College of Obstetrics and Gynecologists and American Heart Association management guidelines for hypertensive disorders of pregnancy. Spend most of my time talking about preeclampsia, which is my area of research, and its long-term cardiovascular associations, and discuss the importance of postpartum follow-up in women who've had an adverse pregnancy outcome, specifically preeclampsia. So just to give you a little bit of a sense of how we're thinking about cardiobstetrics in the United States, while much of cardiovascular disease in pregnancy was originally thought to be the scope of the problem, we've started to now incorporate an understanding that adverse pregnancy outcomes, such as placental abruption, hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, and small for gestational age babies or infants have a significant impact on long-term cardiovascular health of women. And APOs, or adverse pregnancy outcomes, are a huge growing problem in the United States, specifically because of advanced maternal age and increased contribution of cardiovascular risk factors to pregnancy-associated problems. So what is the scope of hypertensive disorders of pregnancy? It is one of the biggest morbidity and mortality causing problems globally. About 2 to 8% as a percentage of pregnancies are affected. It is one of the leading causes of maternal deaths in the United States. In Pakistan, it causes about 25% of maternal deaths are from hypertensive disorders of pregnancy. So it's not a small problem. And the incidence of hypertensive disorders of pregnancy in Pakistan has also increased over time. This is data from your 2019 paper in Pakistan. Like mentioned before, the maternal mortality in Pakistan is also high. While it is high in Pakistan, it is also concerningly very high in the United States for the amount of expenditure on healthcare. So hypertensive disorders of pregnancy are 4 main types, and I'll spend a little more time talking about preeclampsia. One thing that I didn't really put in here is HELLP syndrome, which is a very severe form of preeclampsia. So when we look at preeclampsia and eclampsia, it's new onset hypertension of greater than 140/90 after 20 weeks with some associated end organ dysfunction. Gestational hypertension, it's not so benign sister, but it is not associated with end organ damage and hypertension, but also new onset hypertension. And the other more chronic types of hypertension are chronic hypertension that become a problem during pregnancy with chronic hypertension and superimposed preeclampsia. So the criteria for preeclampsia diagnosis is anyone who's had a blood pressure greater than 140/90 on 2 separate occasions, at least 4 hours. Greater than 0.3 grams in a 24-hour time frame, decreased platelets, increased creatinine or evidence of evidence of acute renal dysfunction, increased transaminases, increased pulmonary vascular edema, and any new onset headaches or visual symptoms. And this is a catastrophe if not acted on appropriately, and it should be a really big warning sign in pregnancy. So what do we know about preeclampsia and why does it occur? Nobody really knows what causes preeclampsia. There's a lot of theories that it is, associated with a whole bunch of problems, but I think what stress or increased genetic problems where placentation, which starts during the first trimester, is incomplete. And while the placental arteries need to be normal and plump and vasodilated, the spiral arteries in the placental placentas of women that are affected with preeclampsia are narrow and shallow and vasoconstricted. And because of that, there is incomplete placentation that causes a milieu of anti-angiogenic problems within the placenta. What we do know is that there are 2 biomarkers, most of my research is on this, where these biomarkers called SFELT and placental growth factor are greatly impacted in women who have preeclampsia, where SFELT is an anti-angiogenic biomarker that causes is associated with vasoconstriction, and incomplete placentation is increased. And the peripheral effects of preeclampsia are because of an increase in SFELT. In some countries, not the United States, but some European countries, this SFELT placental growth factor ratio is considered as a test to diagnose early onset preeclampsia. So what happens in preeclampsia versus a normal pregnancy? We know that in normal pregnancy, there is an increased cardiac output and decreased SVR. That kind of normal physiological change is altered in preeclampsia, where you have impaired hemodynamic adaptation, increased MAPS, and increase in SVR and decrease in cardiac output. The renal flow is affected as well, plasma flow, which needs to be normal and greater than 75% increase during pregnancy, is impacted and causes decrease in GFR and results in proteinuria. Preeclampsia is also associated with insulin resistance, increased dyslipidemia, increased free fatty acids. And the more severe form of preeclampsia, which is the HELLP syndrome, is largely because of subclinical activation of the coagulation system, where there is a consumptive coagulopathy and decreased lifespan of platelets, leading to multiple catastrophic problems in these women. One thing that we do end up getting asked to see sometimes are women with preeclampsia with severe features, primarily because they also present with severe diastolic dysfunction and can present with pulmonary edema as well. These are women who have had very severe onset hypertension with blood pressure greater than 160 over 110, CNS symptoms, thrombocytopenia, pulmonary edema, and renal dysfunction. So what can we do about it with preeclampsia? And this is something that we do in the United States, is prophylactically consider aspirin in the high-risk group. If you are a woman who's had a previous history of preeclampsia, or a type 1 or type 2 diabetic, or have had previous history of or current history of autoimmune disease such as lupus or rheumatoid arthritis or chronic hypertension, and have current multifetal gestation or renal disease, the ACOG will actually prophylactically recommend that these women be started on 81 milligrams of aspirin about 12 weeks on. The idea is that aspirin inhibits, can inhibit thromboxane A2, and thromboxane A2 causes platelet aggregation. And so in that way, it will prevent platelet aggregation. And that's the theory behind the use of aspirin. Women that have, obesity, or have a family history of preeclampsia, or of African-American race, or elderly pregnant, as we call, or elderly pregnant women, can also be considered on aspirin. And that really depends on a shared decision-making between patients and their MFMs. So this is a nice study, and I put it in here because there's been a lot of talk of what kind of medications can be used in pregnancy. And this was a study that came out recently in the Lancet that was done in Nagpur in India, that looked at about 900 women that were treated with nifedipine, labetalol, and alpha-methyl-dopa. And what it found that the primary outcome was actually of decreasing blood pressure was actually well achieved in the nifedipine group. So in terms of efficacy of controlling blood pressure during pregnancy, nifedipine can be a first-line agent. I know that in many resource-limited nations, alpha-methyl-dopa and labetalol are more commonly used, but nifedipine is a good option. So our guidelines talk about management of severe hypertension and non-severe hypertension in pregnancy. If you have severe hypertension greater than 160 over 100 and any of the end organ damage problems, that is a medical emergency. It requires the patient to be admitted into the hospital, closely monitored, starting first line, either IV labetalol, IV hydralazine, or short-acting nifedipine, like I talked about, intravenous magnesium. Magnesium doesn't really control blood pressure, but it helps in prevention of seizures and preeclampsia with severe feature problems. And sometimes, in some cases, nitroglycerin in the setting of severe pulmonary edema. If you do not have a patient with severe severe hypertension, such as blood pressures that are in the 140s to 150 systolic, diastolics, 90s, you can actually start any of the other agents orally, and would require maternal and fetal checks. A whole slew of antihypertensive therapy can be considered. Angiotensin converting enzyme inhibitors and ARBs are generally not recommended in pregnancy. Beta blockers can be started, especially if they've been on beta blockers. There's some concern about atenolol and metoprolol associated with intrauterine growth restriction, but labetalol is safe and can be started. Alpha adrenergic agonists such as alpha-methyl-dopa, calcium channel blockers, and vasodilators can also be considered. And this is the problem. This is where I think the field of understanding what preeclampsia does to a woman in terms of long-term cardiovascular risks is why cardiologists should recognize this. The American Heart Association guidelines for prevention actually do recognize preeclampsia as a sex-specific enhancer of cardiovascular disease. And I think that there has been thousands of different studies looking at preeclampsia and association, both short-term and long-term. And I think one study like this, which looked at, looked at several different studies and was a very, very good meta-analysis, really looked at what kind of cardiovascular outcomes are strongly associated. And here you'll see that, yes, well, preeclampsia is associated with a higher risk of developing coronary artery disease, heart failure, and stroke, but that risk is even higher in the first 10 years. And that's where I think the biggest prevention inroads need to be made in these women. Most of these women are lost to cardiologists and primary care doctors in postpartum timeframe. They don't really see us. They don't even see their general practitioners. And after having a poor outcome in pregnancy, they're largely isolated. Many of them actually have developed chronic systemic hypertension and are not really educated about their risks and don't really know what kind of health promotion and what kind of prevention they need. And I think that is the biggest impact that we as cardiologists and primary care doctors and MFMs can make in the lives of these women is providing them with that education and their health assessment and prevention risk, which they don't really have. We also know that hypertensive disorders of pregnancy are associated with, long-term cardiovascular risk, which we talked about, but also premature aging. This was a study that came out from Mass Journal last year, and it looked at not only was that hypertensive disorders of pregnancy were associated with, the current understanding that yes, it is associated with increased coronary artery disease and heart failure, but also vascular aging and valvular dysfunction and premature valvular dysfunction, which is a huge problem. So what can we do? Women, once they've had a poor problem with blood pressure management, I think recognizing that blood pressure monitoring during pregnancy is important, but blood pressure monitoring postpartum is also important. Stressing the fact that about 50% of these women will remain hypertensive about 2 to 3 months postpartum. This is where they get acutely hypertensive, higher chances of stroke in this time frame. They're not on medications, they're lost to follow-up, and they're fairly isolated. Also recognizing that 10% of these women then will develop chronic hypertension at the end of 1 year. And I think the problem that we deal with a lot is that even though we refer them to cardiologists or primary care doctors because they've had babies and life-altering events, their postpartum clinics is very, very, very less common. Be able to do this safely and effectively at home and then call their practitioners with problems is, I think, a huge issue here in the United States. And ACOG, as well as the AHA, recognizes the postpartum time frame as being a critical problem, critical time frame for educating these women. And so in general, cardiologists and OBs and prevent long-term complications and change their trajectory. Thank you.
Thank you very much, Dr. Sharma. That was a fantastic talk and really addressed a very prevalent problem in Pakistani women who are pregnant. As you're all are well aware, the CLIP trials were done across Mozambique, India, and Pakistan. And a recent meta-analysis that was just published with Dr. Bhutta, one of our faculty at AKU, showed that actually the interventions didn't improve maternal and fetal outcomes. That probably had to do with the fact that the community health workers probably didn't do enough visits. And then if you do a community level intervention without actually enhancing the facilities, you're unlikely to improve outcomes down the line. Our next speaker is Dr. Uzma Khan, who is a professor of medicine at University of Missouri. And she will be speaking on on obesity and diabetes and connecting the dots in women heart disease.
Thank you very much. Let me just share my screen here. Okay, thank you very much. And I really appreciate the speakers before me. And also, I'm really honored to be speaking today. Dr. Garima's presentation was excellent as an introduction to my presentation. I'm going to talk about obesity and diabetes. And as you all know, I'm an endocrinologist, and the one thing I use every opportunity to talk about is obesity and diabetes. This is something that is not very well recognized in women, but what we do know is if you look at women and cardiovascular disease in general, you will see that the cardiovascular mortality in women is much greater than men. When you look at obese women, they have much higher cardiovascular risk compared to obese men. And 64% is significantly higher than 46%. Diabetes mellitus has a much greater cardiovascular risk for women compared to men, 19% compared to 10%. And diabetic women are less likely than diabetic men to be treated for cardiovascular risk factors. And women are 55% less likely than men to participate in cardiac rehab. This sets up women to have a higher cardiovascular mortality. But the funny thing is, if you look at heart failure, which is one of the topics we're discussing today, longer than men. The problem is those additional years that they have greater psychological and physical disability, and the care is suboptimal compared to men. Not surprising because, as everybody is mentioning, there are hardly any good research studies done that look at looking at the health profile for Pakistan, if you look at disproportionate contribution from communicable maternal perinatal, there's also a big contribution from cardiovascular diseases. And one thing that is going to be coming to you all cardiologists in the future is going to be women that are overweight, because we have more overweight women in Pakistan, women that are obese, and women that are physically inactive. And that's going to be something that we have to learn to identify and treat, and especially if we can prevent. When we talk about heart failure pregnancy, everybody talks about really the cause is not known. But what we do know is it has some association with perinatal health, is in the group of countries that is not doing too well in this area. However, when you look at other causes of cardiomyopathy, it's important to recognize that it's not just pericardium cardiomyopathy that we're talking about. Other causes of cardiomyopathy are now catching up in women that are pregnant. There's a significant difference when you look at age. Women with cardiomyopathy are older. They have more diabetes. They have more peripartum hemorrhage, and more of them go for cesarean sections. However, heart failure in women is a little different compared to men. Many of the studies have looked at it but not specially targeting. They were not designed to look at women and heart failure, but when they went back and looked at the studies, they found some significant differences. So in the WHI cohort, there was higher BMI, increased the risk of heart failure in women in a dose-response fashion. And hypertension caused 2/3 of the population attributable risk for heart failure. And in the InterHeart study, the psychosocial factors had higher cardiovascular mortality for women as compared to men, and exercise provided a greater protective benefit. Heart failure in women, when you look at the different categories of heart failure, it's the heart failure with preserved ejection fraction, something that needs a provider to be aware of, appropriately diagnose, and failure that's more common in women. And when you look at heart failure in diabetes, you'll notice that we have known now since 1974 that diabetes increases in men and 5 times in women. Traditionally, when you talk about women, everybody will say estrogen protects women from heart disease. And under baseline conditions, that is true, because the female heart has a higher expression of NOS, and there is decrease in ROS, the reactive oxygen species, and they are more insulin sensitive. But when you have diabetes, that protective effect from estrogen is lost. There are other causes of heart failure in diabetes also. You can have underlying ischemic heart disease, but then diabetic cardiomyopathy is a very special type of ventricular dysfunction in diabetic patients. And it's independent of ischemia or hypertension in these patients. There's impairment of ventricular remodeling. There's impaired metabolism of the cardiac cells, where they use more fatty acid but decrease glucose utilization. And there's increased myocardial oxygen consumption. There's also decreased cardiac efficiency. And as I pointed out to you before, you'll notice that the effect of diabetes on heart failure with preserved ejection fraction is the main problem. The important thing to identify is we now actually have medications like the SGLT2 inhibitors that can improve outcome in these patients. Lowering glucose in these patients will help, restricting diet and increasing exercise. Heart failure in women is the one that's associated with the cardiometabolic profile. 68% of women will have this problem. 70% will be obese, 52% with diabetes mellitus, 90% with hypertension, 62% with hyperlipidemia. Just 20 weeks of caloric restriction and aerobic exercise causes a significant improvement in peak oxygen consumption as well as functional class in these patients. And just 21 days of sodium restriction will improve blood pressure, stroke volume, ejection fraction, and diastolic function in these patients. Outcome in these patients with diabetes is worse. And multiple trials have shown that patients that have heart failure with preserved ejection fraction and diabetes have worse outcome, even in patients that have the same condition but without diabetes. And diabetes by itself is an independent predictor of death. However, again, these trials were not done specifically for women, and those are needed. What we do have is some small trials, in one where you had analysis of mortality in women after a myocardial infarction, and these women had diabetes. It was higher compared to men, especially in the age group that was less than 64 years of age. How do you treat these patients? So heart failure with reduced ejection fraction, the standard treatments that are used, diuretics and salt restriction, beta blockers, RAS antagonists, mineralocorticoid receptor antagonists, and I want to point out a new group of medications. These are anti-diabetic medications, but I think in this group of cardiologists, where I want to point out the importance of recognizing obesity and diabetes as a risk factor for heart failure, I want everybody to be aware of this new group of medications, which actually now has significant use in the cardiology field. When you have heart failure with preserved ejection fraction, which again is the more common type of heart failure in women with diabetes, diuretics and salt restriction will help. The evidence for beta blockers is less convincing, and there was no difference in mortality. RAS inhibition did not show beneficial, substantial benefit in women. We did use medications like spironolactone, which are the mineralocorticoid receptor antagonists, and they are beneficial in women. The special benefit is SGLT2 inhibitors. In general, definitely for diabetes, but especially for women, there is a significant benefit. I'm not going to go into the details of how we dose this group of medications. There are specific indications and dose modifications that are needed. I really want to point out the fact that when you look at indications, there's actually a reduction in risk of MI, stroke, and cardiovascular death in adults with diabetes. There's also a risk in hospitalization for heart failure in people with diabetes. The contraindication is going to be pregnancy and breastfeeding. Also be aware, because this is a conference that's focused on women, that one of the main side effects of these medications is genital fungal infections, which the patient has to be educated about. So when we look at women with heart failure, in the pregnant state, it's definitely a problem, but we should always consider that there are multiple comorbidities. And especially increasingly, we should remember obesity and diabetes, and these need focused attention. Treatment strategies must be tailored for the woman, rather than just saying we're going to use the same strategy for every person. It's important that we as doctors become very familiar with not just the risk factors, but also the new medications that are coming in. And we also come up with research that's focused in the area of women and heart disease. There are good protocols that are being done in Western countries, but I think, as many of the speakers have pointed out earlier, when we look at Pakistan, we are dealing with many of the cultural as well as many of the issues that are related to healthcare delivery, and we should consider those. The risk factors for men and women are very different. There are many that are common, but we should all be aware of postmenopausal state, autoimmune diseases, as well as the other conditions, including depression and breast cancer treatments that are important to consider for women with heart failure. Thank you very much for your time, and I'm listening to the next session now.
Dr. Uzma, thank you very much. That was a fantastic talk and really important for our part of the world, given a very high prevalence of diabetes, and then obviously all the risks compounded in women that predisposes them to that. So appreciate your talk and highlighting all the important issues around this topic. Our next speaker is Dr. Farhala Baloch, who is an adult cardiologist in the section of cardiology at Department of Medicine at Agha University. She has a very special interest in congenital heart disease, adult congenital heart disease, and pregnancy and heart disease. And she's going to be talking about guidelines for the management of pregnancy with CVD in developing countries of South Asia. Over to you, Farhala. I hope your mic issue has been resolved by now. And while Farhala is figuring that out, I just want to give out a shout out to Dr. Bradley, who's been answering questions in the QA box like a champ. And there are many other questions still for the other speakers as well. If you request you guys to answer them in the QA box. Thank you very much. So Farhala, your slides are up and we can see them, but we can't hear you. Are you still having, yes. I heard something for a second. We heard something for a second, but it's still broken up. All right, so while Farhala is figuring this out, what we can do is maybe address some of the questions that have shown up in the chat box. There's one question for Dr. Sharma. That's how to manage pregnancy with resistant hypertension not responding to treatment. Dr. Sharma, would you like to take that question while we wait for Farhala to figure out the mic issue?
Sure. I think the issue here is if you've got a woman with chronic hypertension and it's has had really elevated blood pressure readings, I think it's very important to have a very detailed conversation pre-pregnancy and do a pre-pregnancy counseling, because these are, as explained in the talk, that these are women that are at high risk of actually developing preeclampsia. So, you know, we don't say that pregnancy is contraindicated. I think they just need a very frequent follow-up, very frequent checkup, starting aspirin in these women, you know, early on after the first trimester and continuing them. I think in terms of what kind of medications can we do, I think you could do all in combination to get the blood pressure down. And I think having a very focused delivery plan for these women as to, you know, how are we going to manage it towards the third trimester is also sort of important. But certainly, you know, we've had women that have had very bad resistant hypertension, and that does impact their pregnancy outcomes. It increase iatrogenic preterm birth, IUGR, and this is definitely a very challenging population. So I appreciate that question.
Thank you, Dr. Sharma. Farhala, are you back? No, we can't hear you. We cannot hear you. All right, perhaps what we could do is maybe call Mr. Faizan, and then he could bring the phone over near the mic, and maybe you could go through the slides like that. Why don't we try that? Do you want to give him a call? Can you hear me? All right, while we get that sorted out, there's another question. Dr. Sharma, if you wouldn't mind taking that. And the question is, why is labetalol now considered first line for pregnancy-induced hypertension?
Yeah, you know, the data is sort of different in different countries. It's considered first line because in terms of the other non-selective beta blockers, especially atenolol, and in some cases metoprolol, there is an association of intrauterine growth restriction, definitely much higher than atenolol. In my own practice, I haven't really seen that a lot with metoprolol. There have been cases and reports in the past. So labetalol is not associated with that. So in terms of trying to add both alpha and beta reduction and blood pressure control is considered safer. Another agent that's also sort of used is propranolol. However, blood pressure control with propranolol generally doesn't seem to be as good. Labetalol is also something that we can give intravenously. And so if you're coming in with a very high blood pressure and with severe features, I think that is something that we can get in very quickly to get your blood pressure down.
Great, thank you, Dr. Sharma, for taking those questions. Farhala, will we be able to get to listen to you? Mr. Faizan, do you get you to turn your mic on?
Yes, ma'am. I'm just calling her up, and we'll be connecting her within 2 seconds.
Okay, perfect. We will wait then.
Yes, Dr. Farhala, now everyone can hear you. Kindly just speak a little bit louder.
Okay, I will actually speak a bit louder. Okay. Sorry, I think the rain is mostly affected to my part, clear AKU. Thank you so much, Dr. Zainab, and it's really a great pleasure for me to speak on this forum. I would like to, before starting my presentation, I would like to say thank you to Professor Khalida Dumro, the Pakistan Garden Society, all the organizers, moderators, and the panelists. And actually, my presentation, the title of my presentation is actually kind of a misnomer, that guidelines for the management of pregnancy with cardiovascular disease in developing countries in South Asia. Because as such, we do not have developed guidelines for the South Asian countries, and I will actually give a way forward that how to develop the guidelines and how to proceed. I do not have any conflict of interest. Let's proceed. So the objective of my today's presentation is what is so far known, what is the standard of the care in the developing countries of the South Asia, what are the differences in the outcomes and the future goals. Let us start with the first objective, the known facts. Because when we talk about the guidelines, the guideline is a very comprehensive kind of a document, and when the guidelines actually developed by the experts, then they actually first collect the data that is already known to that region or that globe. So we all know from our previous webinar series on the 5th and the 8th of August, and today's excellent presentations by the very expert panels, that cardiovascular disease accounts for approximately a third of the pregnancy-related deaths. The blue, the hypertension and the hypertension-related cardiac diseases are the topmost causes now, and there is an increased trend seen in the cardiovascular diseases, or the women getting pregnant with the cardiovascular diseases due to the acquired heart disease in the pregnancy, because of the increasing age, advanced age of the mother getting pregnant, because of obesity, because of the diabetes, and because of the hypertension. So all of these things have actually led to more and more of the patients that we are seeing with the in their pregnancy with the cardiac diseases, both the congenital or the acquired one. We also know from our previous knowledge and the previous series that in the developing countries, only 50% of the South Asian countries actually, the women from these countries, only 50% of the women are able to have an antenatal care. And out of that, 50% or slightly more than 50%, only 50% of the women in South Asian developing countries are actually seen by a qualified doctor, which is an obstetrician or cardiologist. Majority of it seen by bloody healthcare worker, or maybe a family physician, or maybe the more like 46% of females are actually not seen by any of them. We also know that 28%, that is 1/3 of the causes of the maternal mortality in South Asian countries is because of the indirect causes of death, and the cardiovascular diseases are actually classified into the indirect causes of death of maternal mortality during the pregnancy. We We also know, everyone knows that the maternal mortality rate is 1 to 20% in the South Asian Pacific region. The rheumatic heart disease, set of most, followed by the congenital heart disease, and now the emerging is the hypertension and the heart disease, and that's why the Joint Commission International is really much focusing on the prevention of pregnancy in hypertension and mortality due to this new emerging indirect cause of mortality in mothers. We also know that the heart failure and the arrhythmias are the most common presentations in the mothers who have the cardiovascular disease and get pregnant. But so these were the facts that we know. Now, what are the existing standards of the care in the Southeast Asian? If we talk about the local guidelines or the registries, we do not have our own local guidelines in the registry. If we talk about the research papers or the manuscripts or the retrospective and retrospective studies, yes, we have. But if you go through the literature search, then most of the studies that you will find will be a single central retrospective study that will be or an observational study. The review of the previous record that has been done in the various countries belong to South Asia, including Pakistan. So what standard of care actually we follow in our region is the two international guidelines or the consensus, which is the Royal College of Obstetrics and Gynecology that is mostly followed by our obstetrical colleagues. And we, as a cardiologist, actually follow the European Society of Cardiology guidelines that were recently updated in 2018 on cardiovascular disease in the pregnancy. So when we do not have the local guidelines or registry for our own patients of our own regions because of the lack of the very robust data, and we follow the international guidelines, then there leads to some gaps. There are variable outcomes which has been seen between the patients of our area and the Western world. There are the gaps which are seen in the care of the patients with heart disease and their pregnancy. There is no strong teamwork, and there is usually a lack of multidisciplinary approach, especially in the primary and the secondary care level. When we talk about our data, like, because I give the 2 slides on our actually data, so some of the data I actually retrieved from our literature search. The one of the study that I found was actually published by our university in 2016 on the obstetric patients in intensive care unit, and they found that the close monitoring of the high-risk pregnant women and an optimum stabilization of their patients before the intervention improved the outcomes for these women. It was actually a very interesting conclusion that I found in this study, and that actually gave us an signal that we should have a robust system and our own registry or guidelines to develop for these patients to have the good outcomes or the improved outcomes. Another study that was also, it was actually a case report in 2008, September. It was published in an international journal in which they discussed about the present actually a case of a pregnant lady on aortic valve replacement. And they conclude in this case report that the role of the multidisciplinary team in managing the complex cardiac cases during pregnancy is really, really emphasized. If we further proceed with our own literature that can be used or that can be expanded, there was a study done on 28 pregnant women with the cardiac diseases, and it was a study done in a superior thing. And they actually, the most important finding in that study was presented on the by our international speaker in the previous webinar also, that the PCCM, pericardial cardiomyopathy, has highest mortality in South Asian regions. Like, it was only a single central study, so we cannot generalize, but it can represent our country. One of the study that was also a retrospective study. It was done in the it was actually not a single central study, but it was retrospective study, and they actually saw the risk scoring and outcomes in pregnant cardiac patients in a tertiary care center, and they actually used the WHO risk scoring system to see how that risk scoring system is applicable to our region. And they found actually that the risk scoring is well adjusted. So that we can actually conclude from these studies that few of the findings, like the most important cardiac diseases in the pregnancy, the diseases which have the worst outcome, the emerging trends, and how the international registries or their scoring systems can be validated. These local studies actually gave us some answer to some extent with some limitations, like the lesser number of the patients, single center studies, and the next of study like the retrospective studies. But nonetheless, these studies are a good source for us, for the South Asian developing countries, to actually utilize them to make a consensus and bring them up in our development of guidelines for our own patients. There was another study which was actually also a single central study in which they saw the fetal-maternal outcomes of pregnancy with the mitral stenosis, and they found that the heart disease in the pregnancy should be carefully managed in a tertiary care hospital to obtain the optimum maternal and fetal outcome. So they continue this actually. So so you can see that out of these all five to six studies that I decreased, some are really recent and some are really 10 years old. You can see that we have the data about our own patients that can be used to make a consensus, but the data is really scattered. We do not have a robust data. We do not have a really multi-centered data from different regions. They are specifically either from the one center or the one country, and therefore, and probably that can be one of the reasons that we are actually not successful still to make a standard of care for our own patients, and we have to follow, like in many other diseases also, the international guidelines. But the thing is that it's because this is a problem and there should be a solution to that. So there should be the future goals to us, to all cardiologists, obstetricians, and the guidelines makers and all the stakeholders actually, that what is the problem? The problem is, I told you, but there is a solution to that. And that solution is actually our future goal. So you can see there is a registry, the ROPIC registry, which is actually affiliated with the European Society of Cardiology. And that was actually established many years back, and it is still enrolling the data all over the world. There are actually 58 centers, 58 countries from the 158 regions that have been participating in this registry. And Pakistan is fortunately one of them. But I went to, if you will go through the details of the participation, then so far till 2017, only 4 patients were enrolled from the Pakistan compared to a lot of thousands of the patients has been enrolled to the registry. Only 4 patients are enrolled from the Pakistan. So there are a lot of publications from the registry, but all the and that actually includes less than 1% of our patients also. But 60%, what I saw from these publications, that 60% of the women were from the developed countries. So even the 40% were from the developing countries, the Pakistanis, the India a little better, but Bangladesh much better from us. But the other thing was that these women that were enrolled in the registry, All of them, because majority were from the developed countries, they got a specialized specialist care with an interest in this field. Means they have a specialist cardiologist, an obstetrician, fetal-maternal obstetrician, they're dealing with those patients. And because of the heterogeneity of the cohort, still the registry is encouraging the developing countries to register their patients so that the results can be journalized. So if I talk about that, what future goals so far we have learned from our own data and the results of this registry publication, the largest registry of the pregnant females with heart diseases, we need the systematic reviews from South Asia countries. We need the local registries to develop. We need increased participation in the ROPIC registry, which they are still enrolling, and as many number of the participations will be there. Of course, our representation and our will be maximized. We need a specialized team of cardiologists, fetal-maternal obstetricians, and critical care specialists, and many, many more. For example, if a female is presenting with a WHO class 4 PhD, then of course a neonatologist and anesthesiologist, and a big team is required. So actually, we need a collaborative effort to develop the guidelines and our own standard set to manage the complex and the simple patients, pregnant patients with the cardiovascular diseases. This is a very important
you've got 1 minute.
Document that I actually received from the WHO. WHO actually tell us that if you are planning to develop a guideline or in the process of developing guidelines, you should actually remember few important golden rules. And these rules actually apply to everyone. These rules are that they should be internationally recognized methods and standards which are used to develop the guidelines. The guidelines should address an area of uncertainty and an unmet need. For example, with us, the local data should be expanded. We should do more prospective studies. We should do more systematic reviews so that we can actually address our own uncertainties and unmet needs. The guidelines reflect the value of right to the health, and WHO has a very good consensus to see the right to the health in every disease, globally a burden disease. There should be a transparent method. That means the user.
Farhala, excuse me.
Guidelines are developed, they are developed by whom, and what was the purpose of developing these guidelines for a particular set of people. There should be a multidisciplinary approach. When we develop the guidelines, we should minimize the risk of bias and the recommendations. And as many of the systematic and comprehensive assessments will be used, there should be a balance between the interventional potential, benefits, and harm in our recommendations. The relevant factors should also be considered. The guidelines should be publicly available, and the last important point in making guidelines towards the process of guidelines that they should be implemented and adopted to the local setting and the context. So if I conclude my talk, in our South Asia countries, developing countries, the standard of care is the international guidelines that we follow from the Royal College of Obstetrics and Gynecology and European Society of Cardiology. We need to develop our own regional standard by expanding our research because the one limitation to the research on these group of patients is the prospective studies, because pregnant ladies with the cardiovascular diseases are not really the good source of good patients to study the prospective study or do the trials. But the systematic reviews and the larger retrospective study with the larger data with the multidisciplinary centers from these developing countries of South Asia can actually give us a good source data. The one more important data source that we can use for the guidelines can be from the international registry. So we have to participate more and more of the institutes from the developing countries of Asia need to register, enroll themselves to the ROPEC registry, and so that a customized data source can be used in the is a need of an hour. And in the end, the pregnancy and the heart team, which includes the obstetrical providers, maternal fetal medicine for the specialties, and the cardiologists, anesthesiologists, and many others as needed according to the complexity of the female with pregnant lady with the heart disease. I would like to say thank you to everyone, and the session is open for question and answer.
Thank you, Farhala. Appreciate that talk on guidelines, and clearly drives home the point that there are no guidelines, and we need to be participating in registries and developing some for this part of the world. So at this point, I really appreciate all the speakers who have brought home really important lessons around pregnancy and heart disease. I'm going to put some questions forth to our panelists. We don't have a lot of time. We just have about 10 minutes left to the end of this session. For the speakers, if you wouldn't mind just looking at the QA box and seeing if there are any relevant questions. My first question is directed to Dr.
Yes, my presentation is over, so now my network is back.
Yes, thank you, Farhala. So, so my first question of the Pakistan Hypertension League, and is a big name around hypertension guideline development for our region. My question to you, sir, is what are the plans of the PHL and other societies around activities specifically addressing hypertension in women, and specifically hypertension in and what are the plans for next year?
Thank you very much, Zainab, for first of all having me on the panel. Your question is very relevant, and I would like to answer this. Since we started PHL in 1997, we have been dedicating a special session on pregnancy-related hypertension in our annual meetings and other regional meetings as well. In our guidelines, we have given special emphasis on hypertension-related disease in pregnancy. And with the grace of God, we have created a lot of awareness about hypertension in pregnancy and how best to manage it to our family physicians. And with our efforts, now I can see that people not only relying on alpha-methyl-dopa, but labetalol is being used, nifedipine is being used, and blood pressure patients are better managed than in the past. I would like to make some, if you allow me, based on my experience of 40 years in practice. I think first of all, Dr. Khalda must be congratulated for focusing on heart disease in women and creating this awareness for the first time, because it's more or less a neglected segment of the society. Structural heart diseases are not uncommon in our society, and most of them, they go unnoticed, undiagnosed. And some of them are simple diseases, and pregnancy is quite compatible with them. But unfortunately, we don't have a system of counseling the potential mothers before they conceive. And we don't have any referral centers or cardiology clinics in obstetric units. Most of these big obstetric to cardiologists. And I think I would like to take this opportunity to request Professor Haroon and Ishtiaq Rasool that cardiac society should take an initiative or fortnightly clinics in major obstetric units where one of the cardiologists can go with a simple echocardiogram. They can pick up these routine cases and make sure that they don't end up in complications. See, after listening to the distinguished speakers, we realized doctors are patient echocardiograms done more frequently. And I think maternal mortality and fetal mortality to a great extent, which is very high in our society. And by simple means, we can achieve quite a significant reduction. So I think as far as we are concerned in PHL, we are very much focused on hypertension. Dr. Khalid is a witness to it. And the module is focused and dedicated to hypertension-related disease in pregnancy. So I think, but a lot more needs to be done. We need more dedicated sessions, and we need a sort of national conference based on how to prevent and how to manage these cardiovascular diseases in pregnancy. And I think a lot of simple cases like VSD or MVP, or you see a small PS, arrhythmias. So I think the scope is very wide, and I'm glad that we have a number of doctors now, especially from the female gender, and you being the chief there. I think you have to look after your gender, and I do admit that we have neglected females for a long time, but it's time that we should realize that they are the most important part of the society. And I think the first and the most important thing that is lacking in our society is counseling. The counseling concept is not there at all. And from there, the trouble starts. If we have a good counseling service, then I think we can prevent a lot of diseases, and we can make sure that the outcome of pregnancy is positive. So I think with this, I would like to compliment all the distinguished speakers, especially from abroad, Dr. Uzma, Dr. Sharma, and our own homegrown speakers, Farhala and Saira Bukhari and others. And I think guests must be complimented for organizing this webinar, and we need more such seminars. And I think we are now very lucky that in hypertension, we have got a number of choices to treat hypertensive patients. You see, there was a lot of fear about ACE and NIC, that's why we don't use them. But we can use thiazides, we can use nifedipine, we can use alpha-methyl-dopa. Hydralazine is another drug that we can use. So I think, yes, the challenge is enormous. And at PHL, I take the responsibility of disseminating this knowledge to our family physicians. Thank you very much.
Thank you, Dr. Ishaq. That was a good pledge. I'm going to hold you up to it. So my next question is for Professor Dr. Abdus Samad. And this question really is around heart failure we end up seeing in postpartum period. And in your vast and long experience, how often have we seen women recover from that? The data is mostly from the West. We've got that 30-30-30 rule, but in Pakistan, what has your experience been on that front? I would really appreciate your comments on that. I told him he's got to wear a mask when he's on the session, and you can leave your mask on. And you're still on mute, by the way. Dr. Samad, you're on mute. We have to unmute.
Were replacement, and then these ladies used to get pregnant and they go to Jannah Hospital and come back to for follow up to us, and they were all on practically 99% of them were on anticoagulants, oral anticoagulants, and we have to manage the pregnancy with anticoagulation. That was a very major challenge for us in NICVD. These ladies who had replacement of the valves, and then they used to come with pregnancy. As Professor Ishaq said, the people don't have a lot of time to advise these ladies not to have another pregnancy. And I just had a paper reviewed just a few days ago, and this is from the Gulab Devi Hospital, Lahore. It's a hospital for obstetrics gynecology, and they have reviewed 246 patients with heart problem, referred to them from the cardiology services. And I think everybody should read this paper. It's really give you all the, what is the commonest cause of heart disease in these pregnant ladies. And I was astonished, 59% are valvular heart disease. 59% of these 246 patients are valvular heart disease who are pregnant. So the mitral stenosis, I would say that a patient with mitral stenosis, if it is tight, they are going to go into pulmonary edema. And this sometime, even this first episode or pulmonary may be fatal for these pregnant ladies. So Dr. Ghaffar Jatoi used to do closed mitral commissurotomy on these ladies. He used to take these ladies to surgery, and I remember 10, 12 patients, and the surgery is, very minimal surgery, because what they open the side of the chest and then cut the left atrial appendage. They cut it, then put the dilator, Tubbs dilator through it, dilate the mitral valve, then tie the left atrial appendage, and the patient's next day or day after is up and about. And I don't remember any mortality in these first 10, 12 patients. So I think if you have a mitral stenosis patient and we have echoes, and you can do a percutaneous dilatation for them, I think that will be much better to prevent heart failure, because once these ladies go into heart failure, then their mortality, I think, is much higher, and especially for the fetus. Fetal survival is also very poor for these ladies. They go into hypotension and a lot of other complications. But I still think that ladies with pregnancy and heart disease are largely does not receive the attention they need, because they need 3 or 4 times more attention than patients, ladies or gentlemen or old people or middle-aged people, because they have a child, they are growing in their abdomen, the whole fluid and their peripheral resistance, everything is different. And I think our cardiologist and our physician should know the hemodynamics of associated with pregnancy week by week. What happens at 20 weeks, what happens at 32 weeks, and what happens after delivery. After successful delivery, these patients, my own experience is they are not out of danger. Whether they have pulmonary hypertension, whether they have valvular heart disease, that may be the time. If they go home, they may die suddenly at home, because that's the time that we must follow them. So I think this is a very good review for me, reminder of a lot of things we used to do. And I don't see them anymore this time, but we used to have a lot of patients. And NICVD, they used to come from the Dr. Saad Kajafri was the chief of gynecology, and she had very close cooperation with the NICVD, and these patients we used to go and see them sometimes in the middle of the night. We used to go and attend these ladies who have pregnancy. With this pre-eclampsia and eclampsia, it reminds me of one patient, and then I'm going to finish. When I was in final year, you have to have 30 deliveries on your file in order to be able to appear in your final year. You have to go to the obstetrics department, have 30 deliveries. I was on the obstetric service that time, and this lady came and she was hypertensive, and she used to go every 2-3 minutes. She used to have a seizure. She used to have a seizure, and that time, you know, you will be astonished. What was the treatment for that? We had a mask on her face, and we used to put chloroform on it. We used to chloroform to prevent the seizures. And I was on duty, so I was doing all the time to check the blood pressure every 1-2 minutes and put the chloroform, and then check sounds of the fetus, because, you know, ultrasound, these things were not available. So you have that long thing, and then you observe what is happening to the heart rate of the fetus. So middle of the night, I remember Dr. Iqbal Ghulam Ahmad was the gynecologist. She was assistant professor at that time. She came, she stayed there for about half an hour, and she saw this lady having seizures. And she says, it's not the question of saving the baby, it's the question of saving the baby and the mother too, because I don't think this lady is going to survive till morning with these types of seizures. And then she survived. I saw her about 3 months after it. We advised her not to have another pregnancy, but I don't know, because I was on the service for only 30 deliveries. So I think we organize for the pregnant ladies in Pakistan, because I think this is the most neglected. This paper from Gulab Devi Hospital is eye-opening, because very few patients among those 246 knew about contraception. They didn't know what contraception is. They didn't know that you can prevent a pregnancy. If, you know, we advise them no more pregnancy, but unfortunately the lady and the husband does not know how to prevent a pregnancy. So this study says 89% of the females didn't know about different methods of contraception. So I would stop here. So I congratulate the speakers that they have really were sleeping for these topics, and they reminded us of those, especially hypertension, that you have to control the blood pressure using all the medications. I think this is the lesson you must take home. When a patient with severe hypertension comes to you during pregnancy, you must control the blood pressure. Otherwise, this lady is going to die and her child is going to die. And both of them is preventable if you use all the medication, all the combination you use, control blood pressure.
Samad, thank you very much for those. Always, as you know, listening to your anecdotes is fun for all of us. My next question, I think our previous esteemed panelists touched upon this, but I want to ask Dr. Khalda Sumro, in her vast experience, you know, we have a lot of consanguineous marriages in Pakistan. Almost 60 to 70% of marriages are actually consanguineous. For those who didn't know that, and a figure. And we know from a previous talk that a lot of this is diagnosed in pregnancy. If it's known, it's not disclosed because of the social stigma, and that, you know, you've got to get your daughter married. So in your experience, what's been your experience in terms of pre-pregnancy counseling for patients who already know, and in terms of screening? You know, our previous panelists have stressed that this is such an important area. What has your experience been?
So, thank you, Dr. Zainab. I won't take much time because I want to you to achieve your target, that is the time. So, meanwhile, speaking on this topic, you are right that there are social problems associated with the girls if they are having cardiac problems, especially congenital heart diseases, rheumatic heart diseases. We usually see them daily in our practice. And whenever they come to see you, they say that we have this problem when we had pregnancy or during pregnancy. They comes with the symptoms and then they disclose to their in-laws that they are having this problem since childhood. We cannot say about the pre-counseling in our country. There's no pre-counseling clinics, no centers in our even tertiary care units. So we need these centers badly in our setup. We need more workshop, more skilled persons in this field to avoid the increased mortality in women with cardiovascular disorders. If you see the data of the West, we can see that there is decreased mortality in every other comorbid conditions like ischemic heart disease, hypertension, diabetes, when it is associated with the pregnancy, and even rheumatic heart disease, even our neighboring countries. But we haven't yet overcome our difficulties in our setup. This is because of the lack of infrastructure, drainage, lack of our trained persons in our community, and less equipped hospitals. I'm not talking about the urban areas hospitals. They are definitely having facilities like Aga Khan and ICVD and many other hospitals. They might be having counseling facilities. But if we are talking about the district headquarters, the condition is really pathetic. We have to give our recommendation for and make our own guidelines to send these recommendations to the government and health departments for the better care of these patients. Even workshops of our doctors in peripheries can do this job. And counseling is really important, but we are lacking. That is my last comment.
Thank you, Dr. Sumro. I think all of the talks today have actually addressed some really specific and different angles around pregnancy and heart. Dr. Samad said a lot of what I learned in med school and residency and fellowship was explored. We need to have more studies in Pakistan to create our own evidence and then and guidelines, both at the society level, at the organizational level, institutional level, and detecting disease early, creating laws around how we can prevent disease in this group, and so on. I am Bukhari, Dr. Farhala Baloch, and Dr. Najma Patel for joining us today and giving really fantastic talks. And I think just like me, I'm sure it was great for the audience as well. Thank you to our esteemed panel, Ishaq, Dr. Samad, and Dr. Sumro. I would like to also thank Dr. Shaq Rasool, our chairperson, who started this without the support of men. I'd like to ask Dr. Haroon Aziz Khan Babar, who's the president of the Pakistan Cardiac Society, now to offer his concluding remarks, and hopefully we'll be done in time then. Dr. Babar, over to you. You're on mute right now. Mr. Faizan, would you mind calling Dr. Babar? I think he may be having some technical problems. Maybe perhaps we can get him to just talk to us through the phone like we did with Farhala. That was a bit of a jugaad.
I'm just doing that.
Okay.
Dr. Zainab, Dr. Haroon Khan Babar is probably not connected. Can I just say something?
Dr. Haroon is here with us. I am just allowing him to speak.
Hello. Dr. Haroon here. Can you hear me?
Yes, we can hear you, sir, now.
First of all, I would like to thank the Jet Pharma for arranging such an informative session and especially getting all the stars of cardiology together. So this was a very learning session, and especially I would like to thank the panelists as well as the presenters, and I will compliment them for such beautiful talks. This field of cardiology, especially in women with heart diseases, is a very neglected topic. We don't come across this more often. So I think we should continue with our presentations in the future, and because this is much needed, especially in the third world. And of course, the panelists from America, the presenters from United States, the presenters from Pakistan, they all did very well. And especially I would like to thank Professor Samad, Professor Ishaq Khan, Professor Ishtiyaq, Professor Khalda Sumro for all the well-organized meetings that it was. Thank you very much.
Thank you, Dr. Babar. And Dr. Ishaq, you wanted to say something before we end? You're on mute. Dr. Ishaq, you are on mute. Uh-oh.
Can you hear me now?
Yes, we can hear you now.
I just wanted to say that we had an excellent session, but only a small thing is missing, and that is Samad Sahib didn't give us any joke today. But I will tell you an interesting fact about maternal mortality, that most of the people in the villages who had second wives, because their first wife died during childbirth, and only then they got an opportunity to marry another woman, and they looked after them better, you see, than the first one. So I think that should complete our session. Samad Sahib, Assalamu Alaikum, sir. Samad Sahib ki baatein jo hain, they are pearls of wisdom and experience, and we have learned a lot. We try to follow him, but it's so difficult to follow his footsteps. But we always try to follow him, and he will remain our role model. Thank you, Zainab, once
Thank you
again
so
for
much.
allowing me
Thank you.
to just say this.
Sir,
Thank you.
sir, thank you. Thank you very much.
Thank you, everybody. Thank you. Thank you. Thanks a lot for joining in. Really appreciate it.
Thank you.
Thank you.
Thank you very
all.
much.
Bye.
Bye-bye.
Khuda Hafiz.
Dr. Uzma, Khuda Hafiz.
Khuda Hafiz, Dr. Saab.
Give my regards to Zubair and everybody.
I will. Assalamu alaikum.
Ali Khan. Chacha Salman sir, thank you.